time to speak yet, I would encourage you to do so. Good afternoon, everyone. My name is Butler. I am the Director of Policy for the TennCare program, and I will be facilitating today's meeting. The purpose of today's meeting is to receive comments on a proposed change to the TennCare program. This change will be referred to as Amendment 42. For those who may not have been to one of our public meetings before, welcome. We're glad you're here. To give you a sense of what to expect, I have a few introductory remarks. I'm going to try to give a very brief summary of Amendment 42, which should hopefully take 3 or 4 minutes. All right, we'll try to get through this part. All right, thank you. Welcome, everyone, this afternoon. To give you a sense of what to expect, I have a few very brief opening remarks. I'm going to try to give a brief summary of Amendment 42, which will hopefully take 3 or 4 minutes. And then we're going to use the rest of our time together for us to hear directly from you. To provide just some background as we get started. On May 24th of this year, House Bill 1280 was signed into law as Public Chapter number 481. Under this state law, TennCare is required to submit a proposal to the Centers for Medicare and Medicaid Services to convert a portion of TennCare's federal funding into a block grant. Amendment 42 is the proposed waiver amendment that TennCare has crafted in accordance with Public Chapter number 481. In Amendment 42, TennCare proposes to receive a block grant of approximately $7.9 billion from the federal government to support the operations of the TennCare program. If approved, this amount would be a significant increase in the amount of federal funding TennCare receives each year. Under TennCare's proposal, the block grant amount would be increased each year to account for inflation based on projections developed by the Congressional Budget Office. TennCare's proposed block grant is based on average TennCare enrollment during state fiscal years 2016, 2017, and 2018. Under the proposal, if TennCare's enrollment grows beyond the average enrollment during that base period, the block grant amount would be adjusted on a per capita basis in order to account for the increase in enrollment. Under Amendment 42, TennCare also proposes an array of flexibilities that are intended to improve the quality and effectiveness of the TennCare program and to reduce certain federal requirements that create administrative burdens, but which add little or no value to the program or its membership. Under Amendment 42, certain TennCare expenditures would not be included in the block grant. These would include services that are currently carved out of the TennCare 1115 demonstration, outpatient prescription drugs, disproportionate share hospital payments, and other uncompensated care payments to hospitals, expenditures made on behalf of individuals who are duly enrolled in Medicare and TennCare. Excluded from the block grant would be disproportionate share hospital payments and other uncompensated care payments to hospitals, expenditures made on behalf of individuals who are duly eligible in Medicare and TennCare, and expenses which are not classified as medical assistance expenditures. Under Amendment 42, these expenditures will continue to operate under the payment and financing processes currently in place. Under Amendment 42, state funding for the TennCare program would be subject to a maintenance of effort requirement based on state TennCare expenditures in 2019. So, there you have a very brief overview of Amendment 42. I hope most of you have had an opportunity to review the materials that TennCare has made available online. Momentarily, I will open the floor for comments, and that is the purpose of today's meeting, is to hear input from the public on TennCare's proposal. In order to hopefully make things run as smoothly as possible, I'll be calling on individuals who indicated as they came in that they would like to speak. If you're here today wishing to speak and you haven't signed up to do so yet, please either come up here to the front table or try to get the attention of one of our team members and we will get your name. When you're recognized, Jordan here, who's at the front, will bring you a microphone. We ask that you wait until he gets to you. In order to speak, we want everyone in the room to be able to hear what you have to say, and it's very important for us at TennCare that we're able to hear everything that you have to say. When you're recognized, I'd ask you to come, I'd ask you to simply be mindful that there are maybe multiple people here today who wish to speak. We want you to please take as much time as you need to offer your comments. We just ask that you simply not take more time than you need. Hopefully, we will have a chance to get to everyone who signed up to speak today. As a reminder, the purpose of this hearing is to receive comments on the state proposal. We are here to hear from you. In order to maximize the use of our time together, I'm not going to be responding to individual questions or getting into debates or anything like that. Just a housekeeping item, we'd like to extend our thanks to the Honey Alexander Center here for the use of their facility. We appreciate it very much. We have this space reserved for approximately 2 hours. We hope that will be enough time for everyone who wishes to speak to do so. If we do run out of time, please be aware that today's hearing is not the only opportunity to offer input on Amendment 42. We can also accept written comments. You can send those to TennCare Director Gabe Roberts at 310 Great Circle Road, Nashville, Tennessee 37243, or you can send them by email to public.notice.tenncare@tn.gov. We consider and review all of the comments we receive, so there's no advantage or added weight given to a comment that's made here today versus something that comes in by email versus something that we're handed in writing. We will review all comments equally. I would remind you that if you do plan to send in comments, please be mindful that those comments should be received by the end of the day on Friday, October 18th, to ensure that we have a chance to review them before the final version of Amendment 42 is submitted to CMS. I think that brings me to the conclusion of my opening remarks. And with that, we'll get started. Again, I would ask, I'm going to call on the names of the people who've signed up to speak. If you'll stand up or raise your hand, let us see you. Jordan will bring you the microphone, and if you'll wait till he gets there to begin speaking. And I think the first name on the list is Congressman Cooper. Congressman Cooper, are you here?
Right here. Thank you. I will be giving spoken testimony, but I would like you to know about the written testimony that is much more complete. Let's be completely honest. Tennessee is one of the unhealthiest states in America, and now we lead the nation in hospital closures per capita. Both of these tragedies are partly the result of our state's refusal to expand Medicaid. And this waiver request not only doesn't help, it actually goes backwards. This is a radical, Trump-inspired plan to treat Tennesseans like guinea pigs. Don't take my word regarding our bad health. Ask Tennessee's own Department of Public Health. Ask Nashville's nonpartisan Sycamore Institute. Ask Senator Bill Frist's Health and Well-Being Index. Here are some examples. Cancer deaths are falling nationwide, but Tennesseans' cancer rates continue to climb. How about Tennessee children? They are more likely to die here than in 40 other states. What if you're one of the 2 million Americans who suffer opioid abuse? There's hope if you live in a state that expanded Medicaid, where access to treatment centers has led to fewer overdoses. But in Tennessee, more of our people are untreated. And what about the health of mothers? Of all the maternal deaths in 2017 in Tennessee, 85% were preventable. Think about that. Many of these mothers might still be alive today if Tennessee had only treated them better by expanding Medicaid. How can we explain our state government's complicity in all this bad news? And Nashville, the city we're in right now, dares to call itself a healthcare capital. Now Tennessee is applying for its 42nd amendment to its federal waiver that's 25 years old. Now we're applying so that we can experiment again on our children and families and our hospitals. Shockingly, the waiver request barely mentions the health of Tennesseans because it's such a low priority. Don't forget that since 2010, we have turned down as a state almost $1 billion a year of health assistance by the federal government. Perhaps if it had been offered by the Gates Foundation, we would have accepted it. Since 2010, we have made the cruel decision to reject federal money for ideological reasons. Never has our state turned down so much money, and we wouldn't even think of doing so for other causes. Only the medical needs of our most vulnerable citizens are scorned. In my written testimony, I go more into the history of TennCare, but let me just suffice to say this. Governor Bill Lee has been handed a page-and-a-half-long bill, HB 1280, by the General Assembly asking Governor Lee to handle the same problems that Governor McWhorter faced a quarter of a century ago. Tight state budgets with little room for the medical needs of our citizens who need it most. Governor Lee has the same response that Governor McWhorter had, only worse, a lot more managed care. In my written testimony, I highlight how the match has been gained by Tennessee. Amendment 42, the waiver request, is really a fourth-generation loophole to get federal government to pay for virtually all of TennCare by allowing Tennessee to use highly theoretical savings in its TennCare program versus so-called budget neutrality, whatever that means. Tennessee is really seeking federal approval to spend as few state dollars as possible on the entire Medicaid population. Once again, our state's proposed TennCare reforms are almost entirely budget-driven, not people-driven. Specifically regarding Amendment 42, I had hoped that Governor Lee's religious faith would have given him more of a heart for the poor, especially as we anticipate the day of prayer and fasting that he has called. The four most grievous defects of Amendment 42 are these, and they are hidden in plain sight. Number one, the main thing that Amendment 42 says is, this is not Obamacare. I understand that our legislature feels that way, but that emotion costs us $1 billion a year. Number two, the second big thing Amendment 42 says is, we want a block grant. The words block grant are very popular with all state legislators. Who doesn't want free federal money with no strings attached? But remember that Medicaid already has many aspects of a block grant and always has. Although to be sure, it's way too complicated and bureaucratic. After 41 previous amendments, Tennessee has enjoyed great flexibility. Of course, federal oversight remains to guarantee a safety net for the poor so that states do not mistreat their disadvantaged citizens. Amendment 42 asks permission to rip holes in the safety net that was supposed to protect all Americans. Do poor Tennesseans really deserve less protection than the citizens of any other state? A strong case can be made that Amendment 42 is illegal because it asks that in a Section 1115 waiver that Section 1903 be removed, but that will be left to the lawyers. The third major feature of Amendment 42 that's flawed is the so-called shared savings. Producing any genuine savings in medical care is a nearly miraculous thing, almost like finding the Holy Grail. I hope we can do it. But in greater probability, it leaves rationing as the only way to reduce TennCare spending under Amendment 42. The state is relying on the tender mercies of its managed care organizations to figure out now how to spend less money on our poor without hurting them. That is the most likely way that any savings can be found, namely denials of care by Amerigroup, United, and Blue Cross of Tennessee. These three insurance companies will be in charge of doing the dirty work while our legislature has washed its hands. Number 4, one of the greatest dangers of this radical waiver request is reducing the little transparency that we have into the workings of TennCare. There are no safeguards in the proposal to help Tennesseans monitor the effects of radical proposals such as the closed drug formulary that has never been allowed in any other Medicaid program. What if your life-saving drug is not on the list? It's not likely to be with only one drug per disease on the list. Conclusion: Tennessee should be granted a waiver, but a waiver for some modification of former Governor Haslam's Insure Tennessee waiver request, not on this dangerous proposal. Our state should not be part of this radical, Trump-inspired plan to further damage the health of Tennesseans and to close more of our hospitals. Thank you.
Thank you for those comments. Then, Jordan, now can we go to Dr. Barbara Dirks and Dr. Dorothy Sinnard? Just try.
Do you want me to just? Hello? All right. All right. Hello. My name is Dr. Barbara Dents. This is Dr. Dorothy Sinnard. We are pediatricians by training, fellows in the AAP, that's the American Academy of Pediatrics, and today we are representing the Tennessee chapter of the American Academy of Pediatrics. Thank you for the opportunity to speak to you today about this Medicaid 1115 waiver, which fundamentally changes the way TennCare is funded and managed by the state. The Tennessee chapter of the AAP has some serious concerns about this waiver, which we would like to address today. We will also be submitting written comments before October 18th. As you know, children in Tennessee make up 56% of all enrollees in TennCare and in Cover Kids. This proposed waiver will disproportionately impact low-income children in Tennessee. We have 4 main areas of concern. These are the overall block grant amount and per capita adjustment, the potential changes in benefits, especially EPSDT, changes to the drug formulary, and proposed oversight of the TennCare program. Our first concern is regarding how the block grant amount will be calculated using the average enrollment over the most recent state fiscal years. As you know, there has been a significant drop in children's enrollment since 2016. The Tennessee AAP has been in conversation with the TennCare Bureau regarding these concerns. We continue to hear from member practices about numerous instances where children have lost coverage but should be eligible. We will continue to work with the Bureau to address this problem. As it pertains to this block grant proposal, we are worried that the state could be underestimating the true number of TennCare eligible children and therefore will not receive the appropriate amount of funds that are needed to provide care for these kids. We're also concerned that the block grant amount assumes that all beneficiaries will maintain the current level of need over the course of the waiver. While the proposal does account for the potential of exceeding the average enrollment numbers for any one category of beneficiary by adjusting the cap, this does not result in additional federal funds for care of existing enrollees. If there is a measles outbreak, if there is a need for additional services to treat opioid use disorders, or if there are new treatment innovations, how will the state deal with overruns in costs that are not due to increased enrollment? We are concerned that this could result in benefit cuts for children. We are also concerned about potential changes to benefits. In this proposal, the state touts its need for flexibility and freedom from federal requirements, which would include the ability to vary benefit packages by limiting the amount, duration, and scope of core benefits. Pediatricians in Tennessee are concerned as to what this would mean for children and the early and periodic screening, diagnostic, and treatment, or the EPSDT benefit, which states are currently required to provide for all children enrolled in Medicaid. As physicians who treat children, we understand the importance of children receiving important preventive services that serve to identify and treat any health conditions early on, preventing them from being more significant and ultimately being more costly to treat. We also want to ensure that kids continue to receive all services that we as pediatricians determine to be medically necessary. Children are constantly growing and developing, and as pediatricians, we know the importance of seeing children and adolescents on a regular basis to support their ongoing needs. While we understand the current intent of this waiver proposal is not to reduce covered benefits below their current level, Tennessee pediatricians want to ensure that TennCare is committed to maintaining EPSDT. We are also concerned about proposed changes to the drug formulary. As currently proposed, the state has requested that TennCare have a closed drug formulary with as few as one drug per therapeutic class. Additionally, the state is asking, in part, to not be required to cover drugs without significant medical evidence which demonstrates effectiveness. Tennessee pediatricians are concerned about this provision. A closed formulary would be in violation of the Medicaid EPSDT guarantee for children by not adhering to Tennessee's responsibilities to ensure that all children receive medically necessary treatment. And again, we are concerned about the state maintaining the EPSDT benefit under this proposal. This change will also significantly limit access to medication that children require to be healthy, as the state is proposing the ability to exclude drugs until such time as the state believes there is sufficient medical evidence of a clinical benefit. Off-label use of medication in children is an unfortunate yet necessary component of a pediatric practice. 1/2 of drugs still have no FDA-approved labeling for use in children. For special child populations such as preterm and full-term neonates, infants and children younger than 2 years, and children with chronic or rare diseases, off-label use of drugs is significant. Additionally, there is no appeals process noted for beneficiaries who may have a medical need for drugs that are not covered. This leaves families without access to treatment for their children that a physician has deemed medically necessary. Finally, we're concerned about oversight. While this proposed waiver argues that the state should be free from federal oversight, there is nothing in it that indicates any mechanism for oversight within the state. TennCare stakeholders should continue to have the opportunity to offer comments or concerns regarding possible program changes. Will the state continue to have open comment periods for any future programmatic changes, such as alterations to benefits packages, enrollment procedures, or the use of federal block grant dollars on alternative public health programs outside of TennCare? We are concerned that the state is seeking unilateral control of TennCare without seeking input from individuals who are serving these low-income beneficiaries on the ground and have in-depth knowledge of their needs. As one of many stakeholder groups with a vested interest in continuing to have a TennCare program that effectively serves the low-income residents of this state by providing much-needed health care coverage, we encourage the state to implement some type of oversight for changes being made to the program. As pediatricians, we can offer you insight into the specific healthcare needs of children, which vary from the needs of adults, and how any potential changes could impact the majority of TennCare enrollees and their families. Thank you.
The next speaker on our list is Sandy Rice.
My name is Sandy Rice, and I live in Suwanee. I've been a nurse for over 40 years and a nurse practitioner in both family practice and oncology for the last 20. For the past 2 years, I have volunteered in a clinic in a poor, underserved rural area just 90 miles from Nashville. Open 2 days a week, the clinic does not accept Medicare, Medicaid, or commercial insurance due to the administrative costs this would require. Sometimes we see individuals with coverage who cannot get into or find a primary care provider, but more often we see people without any insurance at all. They've never had insurance or routine health care. Neither have their parents, their grandparents, spouse, or extended families. They come in for episodic care, coughs, stomach aches, rashes, spider bites, and things that might look like the cancer. And while they are with us, we find that they have undiagnosed or poorly managed hypertension, lung disease, diabetes, arthritis, and a variety of other chronic and acute illnesses. We treat them with education, medication, diet, and exercise, and hope they come back. Our patients work, but their jobs are seasonal, injury-prone, at poverty wages with no benefits. Some have custody of grandchildren, care for a disabled child, a dying parent or spouse, or check on a variety of relatives needing assistance. All these jobs are undervalued, not unskilled. These Tennesseans need Medicaid expansion, not a half-baked Medicaid block grant experiment that may well be illegal, but will definitely delay quality, accessible, affordable health care for yet another generation. Freedom, flexibility, and cost savings are the stated rationale for this radical change. Without federal oversight, and given Tennessee's history, I have no reason to believe that freedom and flexibility will result in anything but fraud and abuse. Cost savings will mean cuts in the care of our most vulnerable patients' care, including children, parents, pregnant women, and the disabled. Rural communities and hospitals will be in greater peril. The number of uninsured will rise. Our already shameful health rankings will fall further into the 40s. Governor Lee promised to help rural communities and that he had a health care plan. I see nothing in this Medicaid block grant that will benefit any Tennesseans. We need what 36 other states have adopted for years and have documented success in patients with chronic disease, addiction, mental illness, and rural care. We need Medicaid expansion, and we need it now. Thank you.
Is Claire Sullivan here?
Check.
Hi, I don't have prepared comments, but I did want to speak. I'm a retired nurse practitioner. I served on the EPSTT advisory committee that developed the standards. My name is Claire Sullivan. Is it on?
It's on.
Okay. I'm a retired nurse practitioner and have served with TennCare on the EPSDT committee and also worked in the Department of Health during the period of disenrollment in 2005 to 2008, trying to establish a safety net for those people who lost their TennCare benefits at that time. I'm currently serving on the health committees of the League of Women Voters Nashville and the Tennessee Healthcare Campaign. And I just wanted to raise some questions. I'm trying to work on preparing comments, but I really don't feel that we have enough information to do so, and I'm very surprised by the vagueness of the proposal that's currently Amendment 42. I sat through as much of the debate on this issue of the block grant as I could in the state legislature, and I was led to believe that the flexibility that was sought was to be limited to financing mechanisms. And yet we now learn that TennCare is requesting flexibility in the formularies, the amount, duration, and scope of benefits, optional benefits, and something called target populations, which haven't been defined. I think my colleagues at the American Academy of Pediatrics did a great job kind of outlining the concerns related to those issues. I'm particularly concerned about the lack of oversight as well. Please don't say that oversight is going to be provided by our state legislature. That's not the way to run a health care program in the state. There have been, I think, previous examples of where TennCare has reached out to stakeholders, such as the EPSDT committee. And even though it was criticized at the time, I think the work that was done on the safety net committee really did help protect, people faith. I'm not clear what the appeals process is going to be if a medication that's needed is not on the list, or the only one on the list is one that's contraindicated for a patient. I don't want to go back to the time where, as a provider, you're filing appeal after appeal after appeal, and waiting to find out, what's going to happen to your patient. And also, I'm very concerned that the criteria that's been proposed for the formulary sounds like it's one of cost and not cost effectiveness. And we know that sometimes a slightly more expensive medication can, in the long run, have a much better outcome for a patient and prevent, a worsening of their condition. I'd like to hear examples of who the targeted populations are. I'm sure there's some really positive things that could be done in terms of designing extra benefits, for some folks, say diabetics who might need nutritional interventions, but that hasn't been described. And it's very hard to comment on this. And the other missing piece, I think, what are the metrics that we're going to use to measure whether TennCare really did achieve quality in healthcare provision and better outcomes for people? Again, that's just incredibly vague. And I can't speak for CMS, but I would never approve a proposal with this level of unclarity and long negotiations or lawsuits at the other end. And I just really urge TennCare to take some time to put this detail in at the beginning so that you have all these advocates in this room on board with you if you're going to move forward. But truth be told, full disclosure, I really don't feel this is the right approach either, as my other colleagues have said. We'd like to find some way of being constructive about this, but I think the best route for our state would be to expand Medicaid in some way. So, thank you.
Thank you. Our next speaker is Linda Sherrill. Is Ms. Sherrill here? Right here, Jordan.
Thank you. My name is Linda Sherrill. I live in Monteagle, Tennessee. I am the state director for the Tennessee Small Business Alliance. I've spent a significant part of my life in the accounting profession. I am a CPA. And in reading through this waiver, a number of questions came to my mind. A not insignificant part of my career was spent in the healthcare industry, and I have lots of experience in building budgets, managing budgets, and monitoring budgets. That goes to my first point. You have stated in the waiver that Tennessee is one of the most efficient states in the nation in terms of managing its Medicaid program. My question is, how are you going to make something that is in the top 5 in the country more efficient, and where are those budget cuts going to come from? In my experience, the cuts can come from 3 significant places. You can either manage, cut eligibility and thereby enrollment. You can cut services, cut benefits, or manage benefits in a way that cuts the amount of services that people get. Or you can cut payments to providers, hospitals, physicians, pediatricians, to providers. My understanding is that you're contracting with MCOs, and I think Congressman Cooper said it very well, that those MCOs are going to be the ones that will be the bad guys when those savings, quote unquote, are passed on to the MCOs. Now, we found out this morning that some of the cuts and some of the efficiencies were due to our drop in the number of people who are covered. The census data shows that in 2018, 17% more children were disenrolled. That was in addition to a not disenrolled, but not covered. That's in addition to a 33% rise in the uninsured in children in 2017. So I guess that's one way to make the program more efficient and less expensive. I was interested in what the pediatricians had to say. I have talked to pediatricians myself who talk about children who show up in their waiting rooms, parents not even aware that their insurance company, that TennCare had dropped them. In one situation, I know a mom that had twins. One of the children had been dropped, the other one was still enrolled. So that goes to my second point. I would like to see more transparency and more accountability from TennCare before we move to a completely new program. Merits aside, I would like to see accountability and transparency on how TennCare is managed now. Thank you.
Thank you. And I will ask, as we come to you and it's your turn to speak, it would be helpful just to maybe stand and to speak very closely into the microphone. I'm hearing everyone, which I think is, as long as we're capturing the input, but I know that there's some challenges hearing in the back, so it will help us if everyone will speak very directly into the microphone. I think our next speaker is Ms. Kathy Buckner. Ms. Buckner?
Yeah, you have to speak directly into the mic.
Hi, my name is Kathy Butler, and I'm legally blind, and I'm also now 65. Before I was 65, I was a caseworker for 15 years. I worked with homeless people, and during that time, the state of Tennessee stopped having open enrollment periods. And so people who are disabled and need help weren't getting it. They're not getting it. They aren't in the future going to get it because you won't expand Medicaid. I also was unemployed I was laid off of that job when I was 58 years old. And so I went and applied for food stamps and went to NCOA for training. so that I could work somewhere else. I'm now in the TBE program with that employs blind people. But before then, when didn't know how much I was going to be making, because you basically work for yourself. And so I had no idea. And I didn't want to have to pay an overpayment for getting food stamps that I wasn't supposed to get. So when my recertification time came up, I didn't go reapply. The state of Tennessee dropped me from my Medicaid, even though I'm disabled, and you just got through saying with this part that that's not supposed to happen. It will happen, it has happened, and it will continue to happen. I, because of that, only went to the doctor 2 times in 5 years. 2 times, because I was too sick to not go. And I went to a minute clinic because they took my Medicare that I had to pay for when I didn't have any money. And because TennCare was supposed to pay my Medicare cost, and they didn't. They wouldn't let me reapply. They said I wasn't qualified. There was no open enrollment, and I wasn't supposed to be getting it. And so I tried multiple times to reapply. In that period of time, last year, I had a prolapsed uterus, which I could not get assistance for because I did not have the other 20% that I would have had to have surgery. So I suffered for a year, 1 whole calendar year, not going to any doctor, not getting any help, because if I had to purchase supplemental insurance, if I had gone to a hospital 1 time in that year, I wouldn't have got any supplemental insurance. Medicare made TennCare recover me, but it's on a 3-month cycle, and if I make more money than I qualify for, then I won't be getting it anymore. But right now I do have it. I've had surgery, but it was horrible that whole year. It was like every time I'd stand up, it was like giving birth to a child. And then when I'd sit down, it was like somebody was ramming it back up in there. And so there are people who suffer right now because the state of Tennessee doesn't do anything. It scares me to death because the state of Tennessee is only kowtowing to the rich. They don't really give a crap about the poor people in this state. Hospitals closing left and right, and people will die because they're not going to be in that magic hour of a heart attack or stroke. People are dying right now because the pharmaceutical companies have jacked up the prices of things so much that, TennCare is not going to pay for multiple medications, but they're not even going to, at some point, they're not even going to pay for the medication like insulin. People are dying of not being able to get insulin. And so it's like I said, it scares me to death because the state of Tennessee is not physically responsible to their poor.
Thank you. Our next speaker is Ms. Libby Thurmond.
Good afternoon. I am Libby Thurmond with the Tennessee Primary Care Association. We are the membership association for community health centers in Tennessee. Our health centers provide comprehensive quality primary care services to over 422,000 Tennesseans, about a third of which are covered by Medicaid. So as you can see from that number, Medicaid is critically important to our health centers and our patients. Our health centers not only provide quality care to patients, but they do so in an extremely cost-effective manner. Based on 2016 data, Tennessee Community Health Centers served about 8.3% of all Medicaid beneficiaries for under 1% of total Medicaid spend. So we appreciate the opportunity to provide these comments. Like many others that have spoken, we'll also be providing written comments. So we have reviewed Amendment 42, and we've talked with TennCare both before and after the release of the amendment. TennCare has reassured us that the waiver amendment does not make changes with regard to enrollment or eligibility, covered benefits, or provider payments. We've also been assured that no funding will be cut from the program and that TennCare intends to utilize historical financial performance as an indicator for shared savings, rather than reducing spending from the current TennCare budget. Amendment 42 does indicate that there may be the potential to cover more individuals eventually, or more services being provided to current beneficiaries in the future. The amendment also mentions the potential to invest in future rural health transformation efforts, as well as using funds to support public health initiatives that could improve the health of TennCare patients. These elements of the proposal could indicate some opportunity, but of course we would want to see specific details around all of those. The three primary components of Amendment 42 are financing, flexibility, and innovation. Amendment 42 outlines a very different financing structure than in what is currently in place for TennCare. TennCare acknowledges that there is risk in this proposal, and they feel that they are prepared to take it on. That may be the case, but Tennesseans also need reassurance that if all does not go as planned, patient eligibility, benefits, or provider payments will not bear the cost. TPCA and our community health centers value innovation, but we would advise against rapid changes without the appropriate support for healthcare providers of all patient panel sizes. We are interested in learning how TennCare would help providers prepare for and participate in any innovation initiatives. Effective innovation must not leave anybody out. Amendment 42 also mentions encouraging competition and value to allow for greater competition between healthcare providers. We would like to offer a word of caution here to ensure the stability of Tennessee's community health centers. Our health centers are mandated by mission and by federal law to provide care to all who walk through their doors, without regard for insurance status or income level. We cannot pick and choose patients based on whether they can pay or not, and we do not do that. The majority of our health centers operate on very thin margins, and they are not able to absorb significant shifts in payer mix should more individuals become uninsured. Nor do they have the resources that private practices may have to invest in more staff and technology solutions to deal with new initiatives. So appropriate consideration and support must be provided by TennCare if increased provider competition is pursued. With regard to flexibility, we understand that TennCare aims to reduce administrative burden by taking on new autonomy with regard to state authority to make changes to the program without seeking federal approval. Per Amendment 42, TennCare wishes to have flexibility to make changes to enrollment processes, service delivery systems, and other elements, again without CMS approval. The example cited in the amendment on this topic notes state contracts. We're really interested to know what other program elements could potentially be changed in this way without any approval. We also are interested to know how TennCare would obtain and incorporate stakeholder feedback when considering these changes. For some of these could be significant changes in the daily lives of our patients. Finally, we would like to request that the state hold a second round of comments after negotiations with CMS are concluded. As many have noted, this proposal does not have all the detail that we would like to see, and there could be some significant changes after negotiations take place. And we really think it's important that everybody have the opportunity to review those and provide additional comment. So that concludes my comments, and we appreciate the opportunity.
Thank you. The next speaker on our list is Dr. Nedva Jackson. Is that right? That's up here, Jordan.
Thank you. I am a family physician, a graduate University of South Carolina School of Medicine on the alumni board. I'm not here to find fault in the U.S. Congress. The Academy has already sent some delegates to talk to people in Washington, let you know what I go through every day. Not here to criticize the legislators here in Tennessee, but I have offered my help to Sam Winston, who's on the Health Committee, and some advice. First, I want to start, how would you like to spend 1 hour on the phone with TennCare to see if a patient is eligible and to see if they receive your payment, your bill rather? How would you like to spend 18 months without getting paid? I'm a family physician. I have 5 state medical licenses, getting ready to get one in Texas. The one to apply in Texas, $975. This is my life. My life for a medical license here in Tennessee is $500. $400 is a privilege tax. I never heard of that. The best Medicaid program I saw and did was in Louisiana. I had that license till March 31st this year. I could no longer afford it. My rent in Brentwood, I hate to say, was cheaper than trying to get something here in Nashville. Just for a small room, $1,800 a month. Now remember, my medical license is $400 every year for privilege tax, $235 every 2 years for the medical board, so I'm making $500 a year. I'm over $2,000. I haven't seen one patient. My malpractice to work less than 20 hours part-time is $200-some. Thank you. To have an electronic health record system, which you need to bill all insurances and TennCare. They don't want paper anymore, even though I do both of those. That's $200 a month. My billing wants 7% of what I collect. My federal DA, which is reviewed every 2 years, is $751. So I'm looking at almost $3,000 a month before I see one patient. TennCare does not provide enough for us to take care, and I'm so sorry about your situation, okay? I also treat opioid addiction. I had to take a course. Last year I spent 80 hours of continuing medical education which every medical board here in Tennessee requires 40 hours every 2 years. That cost me almost $1,000. I treat opioid addiction in Wilson County. I have called the senator to be at where I work for someone tomorrow and see my stories of the patients that I go through. That I see, I hate to say go through, what patients are going through. But then again, I understand that cuts need to be made. But I see people, I had a patient that came into my office on TennCare, but he was driving a Mercedes-Benz. I drive a Nissan Kicks without a CD. So my thing is a priority. In Louisiana, that's the last thing we're going to say. In Louisiana, the system they had, everybody had to have a primary care provider. So they can come to us every year. It was required to get a physical so we can pick up diseases. I see children too, so I relate to what you did. I did ESPT, it was called Kids Med there. Okay? I had nurse practitioners. I can't afford, I did everything myself. I do everything myself, blood pressure, everything in my own private practice in Brentwood. But in Louisiana, everybody had to have a primary care doctor. Anybody signed to me, I got paid $3 a month for that patient, they came or not. And then when they would come to see me, I got paid for that. But before they go to any other doctor, emergency room, which is more expensive, they had to call me. It was something I could take care of in the office. They came to me, which is less expensive than emergency room. For his medications, yes, they do not pay a lot of medications. We have no control of that. Basically, I hate to say this, the ACA physicians were not getting paid. We cannot work for free. Not only do I have these bills, I have a family, I have a house note, I have a car note. Some days, I'm not gonna let my kids and grandkids suffer. I've eaten cereal 3 times a day. The 5 years we went through the Affordable Care Act, where some people only pay $3 a month for insurance. I have my own health insurance to pay. So we understand where everybody's going through. I understand that. But people understand where we're coming from. No, they don't cover obesity. I'm dealing with weight loss. They don't cover opioid addiction because TennCare feels it's something people put on themselves. So we feel this is my personal belief, that patients that need to take more responsibility for their health, put a priority, and the whole TennCare system, whenever it was set up wrong in that it needs to be overhauled completely. And the Louisiana system was a great system. And I took medicated all insurances. I'm on with all insurances here in Tennessee. But you know, most physicians, the headaches, the administrative costs, as you alluded to, and I think you alluded to also, it's so expensive. So most physicians are taking cash. Because that way, where else can you go and get a service? You pay for my knowledge. Anyone drop dead here? I mean, not drop dead, please. If anyone gets sick here, I can take care of you. That's it in my store. I have to go. I have to go see the patient. Thank you very much.
The next speaker on our list, and I'm sorry, I may be mispronouncing your name, is there Mr. Jeff Flayton from NAMI here?
Thank you. Thank you for the opportunity to make these comments. I'm the Executive Director of Nami, Tennessee. We have been working for Medicaid expansion for many years. We were asked to give a position on block grant a while ago. We said no, not knowing about the current block grant, which I've been trying to understand. I do have some concerns about this. First of all, we think that what we need in Tennessee at a minimum is something that covers everybody with mental health issues and with addiction and co-occurring issues. We were working on 3-star, we were moving that way, it didn't happen. We don't want rationing. So when we get into the details of this, to me, block grant means capitated, that there's only so much money. If that's still the case, we don't want rationing. We do not want to have somebody with mental illness sat next to a child or somebody with cancer or somebody in a nursing home to determine who we can cover and can we cover as recommended by the treaters. So one of the concerns we have is what happens if Tennessee does not get everything that you're asking for in the waiver. If we get part of it, are we still going ahead? Because it will weaken, and what are the protections then? And we are a state that is 16th in prevalence of mental illness, but we're 46th in access to mental health treatment right now. And you can talk to our sheriffs about this. We have had so many people with mental illness, addiction, and co-occurring disorders ending up in our jails and our prisons that we're getting pushback. So not treating costs money, and we have to treat everybody. So those are the main things that we have to say. And also, I'm just concerned that there's not a lot of talk about mental illness and addiction in what I've been able to read about this proposal. So what will it mean for those services? And we have the safety net. That's true. It doesn't cover everything. Treatment helps people work. Treatment helps people recover. Treatment helps reduce homelessness, broken families, and we need something that gives more of it. We will be continuing to study this and take advantage of comment situations. And thank you for allowing me to speak today.
Thank you. The next speaker on our list is Louise Hardaway. Is Ms. Hardaway here? Okay.
My name is Louise Hardaway. I'm not associated with any of these state organizations or advocacy groups except as a volunteer. But I know many folks in this room with Tennessee Justice Center and Tennessee Healthcare Campaign, and I have so much respect for all of the healthcare advocates in this room. I mainly just wanted to, you asked for simplistic comments. In its simplest form, I said on my sign, block grant is a blockhead proposal. Now I realize that that's not being really intelligent or proper, but I'm holding here in my hand just a few of the Tennessean newspaper that have come out that have articles, letters to the editor, you name it, that are saying all the same things that everyone in this room today has been saying. Tennessee is not taking care of their sick and their poor and their disabled. And we don't need to cut funding for health care. We need to increase health care funding and provide health care to more Tennesseans. I do want to say a word. I have volunteered for many years with the Hemophilia Foundation, and one of the national advocacy groups, Healthcare Hemophilia Federation of America, has written a letter opposing the block grant here in Tennessee. Hemophilia is a lifelong chronic condition where people experience internal bleeding. They're born with it, they have it their entire lives. Many people with hemophilia and bleeding disorders have to have a very expensive drug to treat they're on a regular basis, or to treat when they're having a bleed or prophylactically. And so many of that whole population, I'm sort of pulling this out of the air a little bit, but about 80% of that population are on some form of Medicare or Medicaid or both on a state or federal health care plan. They're not able to get health care because they have pre-existing conditions, or they can't afford the ACA plans. So that particular disease state, hemophilia and bleeding disorders, will be hurt tremendously by a block grant because it means less money for taking care of the sick and the poor and the disabled of Tennessee. And Tennessee needs to spend more money on that, not less. No to block grants.
Thank you. Is Mary Lyndon Salter here? Ms. Salter, where are you? You don't want to speak? Oh, okay. Matt Steinhauer, is Mr. Steinhauer here? Jordan here in front.
My name is Matt Steinhauer. I'm the pastor of Faith Lutheran Church in Lebanon, Tennessee. And I have 2 reasons to speak against block grants. First, as a pastor of the church, it is a vow of my ordination to speak on behalf of the poor and vulnerable, people who are covered by Medicaid, TennCare in Tennessee, are perhaps among the most vulnerable except for the homeless poor. Those vulnerable human beings are the elderly in nursing home care, children raised in poverty and their mothers, and intellectually and developmentally disabled, who are all created in God's image. My second reason, but more important, is my son Matt. Matt is an adult with Down syndrome, and he is covered by TennCare. The wonderful community of families of special needs children knows full well how difficult it would be to have a single reduction in services we receive to take care of our children and adults. Let me share some of those benefits that we receive. Medicaid provides these treatments for children with disabilities: mental and behavioral health. Will this block grant guarantee that those services will not be cut? Or services for dental, hearing, vision care, physical therapy, occupational therapy, speech therapy, non-emergency medical transportation to appointments, medical equipment and supplies, nursing care to live safely at home, attendant care, assistive technology, case management where a social worker coordinates medical, social, and other services for children with multiple needs. No program is perfect, but as I have experienced, TennCare has served us and our family well. I hope Governor Lee will see the greater challenges that will lie ahead if Tennessee receives a block grant. And I hope he will rescind his request that, if granted, will present harm to many vulnerable Tennesseans. Thank you.
Thank you. The next speaker on our list is Shannon Baker. Shannon Baker.
Hi, my name is Shannon Baker. I'm the Director of Advocacy for the American Lung Association in Tennessee, and I appreciate the opportunity to be here today and share our comments. The Lung Association is the oldest voluntary public health organization in the United States, representing 35 million Americans with lung disease, including nearly 1 million individuals in Tennessee. For patients with lung disease, including asthma, COPD, and lung cancer, having quality, affordable health care is essential. The state's proposal jeopardizes the access to care for the more than 1.4 million patients enrolled in TennCare. Tennessee's proposal would convert much of its Medicaid program to a block grant that would include vulnerable eligibility groups such as children and people with disabilities. The Lung Association opposes block grants in Medicaid programs in general. This structure will not protect either the state or patients from financial risk as the result of an unexpected event that increases health care costs. As the gap between the block grant and actual cost of patient care increases over time, Tennessee would be forced to limit enrollment, reduce benefits, lower provider payments, or increase cost sharing for patients. Under this proposal, current and future administrations would not need to get approval to make changes to benefits and services, putting patient care at grave risk. Tennessee's proposal would also limit prescription drug coverage, as many in this room have already said. This would have dangerous implications for our patients with lung disease. The state would create a closed formulary only required to cover one drug per class and would have the option to completely exclude drugs approved through FDA's accelerated approval pathway. This coverage is not sufficient for lung disease patients, including children with asthma and adults with COPD, to receive the evidence-based care recommended by their providers. While patients with lung cancer could be denied coverage for the targeted therapies approved, and no appeals process is outlined in the proposal to help patients receive these life-saving treatments. The Lung Association has a number of other concerns with the waiver, including exempting Tennessee from federal standards for its managed care program, which includes important safeguards for patients such as standards for network adequacy, allowing Tennessee to change the amount, duration, and scope of benefits, which could allow the state to put caps on services or only cover critical services for certain individuals. Making the TennCare 2 demonstration permanent, removing important opportunities for the public to provide feedback on how the program is serving patients before any policies are continued. These are all important fundamental concerns. The American Lung Association in Tennessee urges TennCare to focus on solutions that are truly a good deal for Tennesseans, promoting adequate, affordable, and accessible health care through TennCare. Thanks very much.
Thank you. I'm going to apologize again. I may not be pronouncing this correctly. Justin Canu, or Canu?
I thought I was supposed to sign in when I came in. I didn't expect to speak, but I'm going to. I'm Justin Canu. I run a thing called the Tennessee Holler. I started the Holler with my friend Holly McCall not too long ago because we wanted to tell the real story about what was going on here in Tennessee. Congressman Cooper just did a great job of starting it, but we're #1 in medical bankruptcies. We're #1 in rural hospital closures per capita. We're at the bottom in infant mortality rate. We're at the bottom in healthcare access. We're at the bottom in opioid deaths. I could go on and on and on. All of these things would be helped by Medicaid expansion. We're in here, and this is business as usual right now, and then they're going to ignore it, and they're going to go do what they want to do. But it's heartbreaking to hear stories like this. It's heartbreaking to hear the stories that I heard when I ran for Congress in 2018, the people that were in a parking lot in Columbia to see a doctor when remote area medical was there because they couldn't see a doctor any other way. These are the people that are behind the numbers that we're talking about. These aren't just numbers. There are real people who are suffering. We could cover 300,000 Tennesseans tomorrow by expanding Medicaid. This program, we don't know if it's going to cover anybody, and we do know that the people who have let this happen are now going to be in charge of a block grant, billions of dollars, and incentivized to save more, and that savings is not going to come out of nowhere. That savings is going to come from cuts like you're hearing from everybody here. And I'm preaching to the choir here, but hopefully somebody in one of those TVs somewhere is going to hear what we have to say in this room and going to hold these people accountable that are making these decisions. This decision is going to hurt people. And this is a faithful state, a faithful community, and we should be protecting the poor, not hurting them. Thank you.
Our next speaker is Tina Claxton. Ms. Claxton, where are you?
I am here as a mother of a daughter who's going to die probably in the next 2 years. We have been on TennCare for over about 24 years. We have been through the cutbacks. We have been through your child's not going to get services because we don't have the money for OT and PT. And go back in Channel 2's history, and I think I was on TV then too, because we got our services back the very next day. It's not an individual thing, it's a we thing. It's we the people, we the state of Tennessee. Our children, our disabled children, are the people who cannot afford insurance. I'm not on this, my daughter's not on this because we chose it. She's disabled. Only option. I just spent the past 6 weeks in appeals with our current TennCare situation for a medication that my daughter is on that keeps her quality of life comfortable. 6 weeks. Doctor prescribed it in the hospital, worked. Didn't see it coming. Her condition is rare. So, I mean, it was amazing. We thought it was heaven sent. And TennCare said, no, you don't get it. She's not going on it. And I said, in our household, it's not no, it's go. Because in 24 years, I've never stopped for her. I won't stop now. Because everybody in here knows somebody. Raise your hand who does not. If you don't know somebody with a child with a disability, raise your hand. Right. Who doesn't know the elderly who are sitting there and don't know what to do when they get denied? Because you get a stack of papers that's 400 pages long. I could fill a room with the stuff I've gotten from TennCare to tell me that we're 2 days late picking up a medication. From the paper alone, I could probably gain my salary off just what they mail out. But I spent 6 weeks, the doctors spent 6 weeks, 2 nurse practitioners, 3 nurses to fight a system to finally come down to the fact, because there's only one drug that treats what she's got going on right now, and it's not on the list. So if it's not on this list, what's going to happen when the block grant comes through? What's going to happen to the rare conditions that come to this state? And I'm going to tell you, my child is 1, and there's 1 in this state born every year, probably 3 or more. She just happened to survive. And it's because I said no. We moved forward. And this entire room needs to move forward with how you feel about this grant, because unequivocally, it needs to stop.
Our next speaker is Joel Alex. Mr. Alex.
My name is Joel Alex. I'm a social worker here in Nashville. A couple comments. In 2018, it's estimated that 15.4% of Nashvillians live in poverty. That's higher than it was in 2017, so that's increasing, and it's been increasing for the past 3 years. Georgetown law indicates that block grants as a whole, like the block grants that are being proposed, increases disparity. My concern is that this block grant, if it's implemented, will increase inequity in our state, both racial and economic. In the grant, it doesn't have anything addressing inequality and disparity. So that's my first concern. The second one is, how does the block grant proposal prevent more people in our communities from being uninsured? We have children in our community, and we've had it that number is increasing. Why are we working on something when we can't even insure the children that are eligible? Not only does this proposal fail to prevent the increase of uninsured, it will almost certainly increase it. In the proposal, the state states, is the state seeking to reduce enrollment and services through the block grant? Maybe not through the block grant, but from somebody on the service level, it looks like the state's trying to reduce enrollment services. And my final point is, I would like to suggest that a public forum be held in Memphis. I think it's unfair that Memphis is not included in this discussion. Thank you.
Thank you. Our next speaker is Mr. Russ Overby. Mr. Overby.
My name is Russ Overby. I'm an attorney with the Legal Aid Society.
You just have to hold it out.
Is this better? Okay. My name's Russ Overby. I'm an attorney with the Legal Aid Society of Middle Tennessee and the Cumberlands. Every year we represent thousands of low-income Tennesseans who depend on TennCare. For many years, organizations who have wanted to shift responsibility for health care from the federal government to the states have proposed a block grant as the solution to that problem. Currently, for every dollar that Tennessee puts into our Medicaid program, the federal government contributes $2. In contrast, in a block grant program, a set amount of federal funding is provided. If the funding is not sufficient to provide the medical services that low-income children, the disabled, and seniors need, it would be up to Tennessee to provide funding for 100% of the cost or turn down these services. It's reasonable to assume that the goal of the federal government in any block grant negotiation will be to reduce the amount of federal funding for medical services over time and shift more responsibility for funding to Tennessee. Under TennCare's proposal, the cost of future medical services will be based on federal projections of future costs. But what happens when there's a breakthrough medical treatment, which is more expensive, but provides better health outcomes, and over the long run will save money? Under a block grant, Tennessee will have to either put up 100% of that funding or refuse to provide the treatment. The proposed amendment will allow Tennessee to spend money that currently goes to provide medical services to other uses as long as they are related to health. This spending does not have to be targeted to TennCare recipients. The proposal reassures us that Medicare dollars would not be redirected toward routine infrastructure maintenance. But what of emergency bridge or road repair? The proposal places no limit on the amount of funding that could be transferred out of medical services, and it makes it clear that the determination of what is health-related is within the sole discretion of the state. This proposal would allow Medicaid funding to replace state-funded programs with Medicaid funding, and the resulting savings, because the state no longer pays for the program, could be spent on anything. Under this proposal, it appears the funds previously used to pay for healthcare services for our state's most vulnerable citizens will be up for grabs without limit. Under the proposed waiver amendment, adults enrolled in TennCare would see their access to potentially life-saving prescription drug therapies dramatically reduced. The proposal seeks to limit TennCare's formulary to, quote, at least one drug per therapeutic class. The advantage of such a closed system, we are told, is that the state could receive a substantial rebate from drug manufacturers by guaranteeing higher volume. The proposed amendment discusses these price savings at length, but does not address the health consequences to patients who may no longer have access to a particular medically necessary medication, or who may no longer be able to access the range of medications necessary to determine the most effective treatment for them. The proposal also seeks to exclude medications released to market through the FDA's Accelerated Approval Program. These medications, by definition, treat only serious conditions for which there is an unmet medical need. Drugs currently on the market via the Accelerated Approval Program include cancer treatments for patients with life-threatening diseases and no effective traditional therapy available. The story of one of our former clients is instructive. Our client had both HIV and hepatitis C. Over the last several years, new drug therapies have entered the market that essentially cure hepatitis with an 8 to 12 week course of treatment. For years, Tennessee refused to cover these treatments enrollees whose disease had not yet caused severe liver damage, even though the standard of care was to treat and cure hepatitis C patients immediately to prevent life-threatening liver damage from progressing and to stop the transmission of the disease. Our client's doctor said she required immediate treatment. However, particularly because of her HIV status. At a hearing on TennCare's denial, TennCare's own doctor agreed that the medical literature unambiguously supported treating her client. But TennCare's formulary rules made her ineligible for the medication. And because she had TennCare, she was ineligible to receive the medication directly from the manufacturer. It took nearly 2 years and a substantial reduction in the price of the medication from the date of this client's denial before TennCare changed its formulary. By this time, our client had died. What will happen to TennCare enrollees with serious illnesses if the program is able to restrict access to new medications even more than it does now? Will low-income Tennesseans be denied cancer treatment, a potential cure for HIV? The proposed waiver of long-standing amount, duration, and scope of service requirements would also restrict access to care. Federal Medicare rules with respect to this require state programs to provide medical services sufficient to meet the needs of 95% of the Medicaid population. The proposal suggests that by waiving this requirement, TennCare could provide additional services to target populations. The proposal acknowledges, however, that TennCare can do this already with federal government approval. The proposal gives TennCare no additional flexibility on this score, but a great deal of freedom from oversight should it elect to restrict services under its new rules. TennCare could, for example, reduce the amount of hospital days it can cover with no lower limit. The proposed waiver of the managed care rules could also result in restricted access to care in the form of reduced network advocacy, solvency, and prompt payment of providers. These are all issues with respect to managed care organizations which have restricted access to care in the past. Our client clients rarely have access to health care if they are not eligible for TennCare. Individuals with incomes below 100% poverty level are ineligible to obtain subsidies on the marketplace. Working low-income people frequently don't hold jobs that provide employer-based coverage. And charity care networks are utterly inadequate to meet the need. TennCare is a vital source for the individuals, families, and communities we serve. Any reduction in the availability of federal Medicaid funding, the restriction of access to prescription drugs, diminished amount, duration, and scope of medical services, and the siphoning away of Medicaid funds to other projects would have a devastating effect on the overall health of vulnerable Tennesseans.
Thank you. Our next speaker is Mr. Tom Starling.
Thank you. Good afternoon. I'm Dr. Tom Starling. I'm the CEO of Mental Health America of the Mid-South. Just a note, as I've been listening to people, we have represented trade association, disability groups, specialty care, primary care, physicians, charitable clinics, pediatrics, caregivers, senior citizens, community mental health centers, addictions experts, mental illness experts, attorneys, mothers, a father who's also a dad, and others. I mean, this is essentially the safety net group of Middle Tennessee, if not of the state of Tennessee. And we're saying that this is just doesn't work. Again, just limitations to the prescription drug formulary is unacceptable. Block grants remove federal oversight and transparency. This particular block grant just lacks so much detail. I kept thinking I was reading the summary. I asked for it twice to figure out that it was actually, that's all there is. Please don't exchange flexibility and potential revenue for medical quality and coverage for our most vulnerable Tennesseans.
Thank you. Randy Horick. It's Randy Horick here. Jordan here in the left side.
Hi, my name is Randy Horick. I'm not a healthcare practitioner. I'm just somebody who's taking the afternoon off to be here because my religious tradition tells me to care about justice. After reviewing the claims made on behalf of this block grant proposal and comparing them to what analysts say will actually result, I can only describe what the state of Tennessee is attempting to perpetrate here as a massive case of Medicaid fraud. The cost of this fraud will be paid in the lives of our neighbors, including one of mine. What you present as an opportunity to return $1 billion in savings to the state is actually a $2 billion siphoning of dollars from the existing program. And it will come largely at the expense of the sickest Tennesseans who need the most and costliest care. What you present as a streamlining of federal rules and regulations is actually a plan that will allow you to rewrite many of the rules in ways that CMS surely would not allow outside of this plan. You are claiming that Tennessee has one of the best run Medicaid programs. This from the state that cut tens of thousands of eligible children because of slipshod, haphazard handling of paperwork. I simply do not trust your administrative competence. On top of that, I personally cannot trust that this plan was born from honest motives by Tennessee state government. This state had the unique opportunity to expand Medicaid, that is, to bring more health care dollars into the state rather than suck them out, at no cost to taxpayers. And yet our legislature allowed Governor Haslam's innovative plan to die. Make no mistake, that is what our state government is willing to allow to happen to our most vulnerable Tennesseans. Let them die. Jesus said he came to bring good news to the poor. You pile bad news upon bad news. Shame on you, Tennessee state government. What in the world is the matter with you?
Our next speaker is Alyssa Lapointe. Thank you.
Hi, I'm Alyssa Lapointe. I'm the incoming advocacy director for Nami, Tennessee, the National Alliance on Mental Illness. And we've heard from Jeff, our executive director, about several of the concerns that we have. I'd like to drill down a little bit more about the pharmaceuticals. We've heard a lot from different groups about this today. But for this population of individuals with mental illness, this is critical. Whether you've been diagnosed with depression or schizophrenia, it can sometimes take 2, 3, 4 different types of medications for you to start feeling the effects and the results of these drugs. And that's because our bodies are different. These medications are different. They affect each person differently. The side effects are different. And one of the key side effects in some of these drugs is suicidal tendencies. So limiting drugs to 1 drug per therapeutic class for this population is dangerous. Is this really what we want to do? Now, I know there's a lot of pressure, but we really need to be looking at how this population of vulnerable Tennesseans is going to be affected. Also, there's been a lot of discussion about the amount, duration, and scope of services. In an ideal world, people with mental illness would have the treatment, prevention services that they need so that they can recover, because we know that recovery is possible with mental illness and substance use disorder. But is recovery going to be compromised because of dollars? That's what we're concerned about. Now, 3 years ago, there was a new component of TennCare put in place called HealthLink. And HealthLink was intended to coordinate physical health services and mental health, behavioral health services for individuals with behavioral health issues. Because we know that individuals with mental illness have a shorter lifespan of 20 years because of chronic health conditions that can also accompany mental illness. So HealthLink was put in place 3 years ago, according to the TennCare website, to improve outcomes, for increased provider accountability, and to improve cost controls for the state. But yet 3 years later, we have no idea how that's even working. So now we're talking about a block grant on top of this. So we would just ask that you proceed with caution, and we'll be providing additional comments. Thank you.
Thank you. Arlene Martin Norman. Ms. Martin Norman, are you here? Join behind you.
Good afternoon. My name is Arlene Martin Norman, and I am a retired government worker and a concerned citizen. I was called this morning, and I really don't have a lot of remarks, but I do know that some of the things that I wanted to say, other people have said, so I won't repeat them. But I did see an article covering the American Journal of Managed Care, and it was saying that 49% of the people in the managed care, they don't even support this. And then another 33% don't even understand what block grants mean, how it would fall out, how it would work. And as a senior citizen, a member of AARP, they have came out against this, and a lot of the people that receive Medicare come under the AARP, we're senior citizens. And that would affect the type of coverage, the services that they receive. And here's my closing remark. If this is such a great idea for our legislators, then let's use the same formula that they decide to use for their medical benefits. Let's use that formula to decide what the block grants will be about, so that our money amount will equal what they receive for their families and the benefits that they receive when they have medical conditions. Use that same formula to determine what the amount will be for those block grants. Thank you.
Ms. Terry Jo Bichelle.
Hi, I'm Terry Jo Bichelle. I have been a nurse for 27 years. I've been a neuroscientist for only 3 years. I became a neuroscientist in order to cure my son, who suffers from a rare genetic brain disorder. And like this lady over here who spoke, and this gentleman over here who spoke, what is amazing right now is that the science has made the breakthroughs. There are cures for these disorders. They are on the cusp of getting into the people who need them, the kids who need them. These rare disorders hit everybody, rich, poor, Republican, Democrat, rural, urban. You don't know who's going to be born with a rare disease. And at this point right now, people with rare diseases often die or become severely disabled and dependent on the system. If we have treatments that can cure these disorders, they can, in the long run, give these people meaningful lives. Lives that they can work, they can go to school, they can have families. Or we can let them become disabled and die because we are not going to spend the money for these treatments. We are going to have death panels to decide who gets a treatment and who doesn't. Because these treatments will not be on a formulary because they don't exist today, but they will exist tomorrow. Is that what we want to do, Tennessee?
Thank you. Ms. Maureen Orkin. Ms. Orkin.
Some people will tell me that you can hear me throughout the room without the microphone, but if you don't hear me, please let me know. My name is Maureen Organ. I'm a retired nurse and healthcare manager. I worked in public health. I've worked in physician practice. I've seen the Medicaid program and all the other third-party payers from a lot of different perspectives over the years. And I know the inefficiencies and ineffectiveness in our current program. I'm deliberately omitting a lot of comments because I don't want to repeat what everyone else has said. I want to stress that most providers that currently participate in this program do it because of commitment, mission, some underlying ethical or moral responsibility. It's not because dealing with this program provides them a lot of money, a lot of satisfaction, or a system that's friendly towards them. One thing that the legislature, our governor, and all the people sponsoring this idea seems to me fail to understand that every person that's able to receive health care improves the health of all of us. And every person who's denied access to health care threatens the health of all of us. This is so basic, but we just don't get it, and this grant does not address it. People don't get care unless they have some kind of third-party payment. We have a huge population with nothing. The Medicaid program's been refined for 54 years. Now, I have to believe that we've learned something. That things that are guaranteed and required are there for a reason, and the things that we have freedom about are there for a reason. It's kind of arrogant, from my point of view, that we think we can do better, reinvent the program, put something together quickly that will probably be a torturous development process. There's two small issues that stuck out to me. One is the focus on fraud. Now, there were a grand total in, I think it's 4 years, of 100 people convicted of fraud. but it was referred to over and over in the proposal, like this was a really big deal. Now, if we deny people coverage because they committed a fraud for a year, that's another group that's going to be uninsured. Another group that's vulnerable and is likely to threaten everyone's health. This big focus on that made no sense to me at all. And the last thing I'll say is that one of the sponsors of this legislation, Senator Bailey, was quoted as saying that Medicaid should be a temporary measure for adults. This evidences to me a lack of comprehension or a lack of empathy for those who become permanently disabled through injury or illness. The sponsor of this legislation doesn't get it. So I'm really glad we all have an opportunity to participate today, and I hope all our comments will be treated seriously. Thanks.
Kim Abernethy? Is Ms. Abernethy here? Did you want to speak? Okay.
I was under the impression also that we were supposed to sign in, so that is what I did when I came in. I really came here with questions, not so much a prepared statement. And then you said you weren't going to be taking questions. I was particularly concerned about the possibility of people who have substance abuse issues and where they were going to fall out in this programming. The Sycamore Institute already says that we are woefully underserved or underrepresented in behavioral health needs being met. I think in 2016 there was 61% of our behavioral health needs were not being met. 61% of service providers were not being met. And I don't see how cutting funds is going to help us meet those needs as opposed to adding funds, since we're so far behind as it is. Further, I was concerned about the possibility or the issues that are going to affect medication-assisted treatments for people with opioid issues, and that is a serious, as many people have addressed, a serious issue here, and that is going to be a problem. People can go across the border into Kentucky if they're a citizen of Kentucky because of Medicaid expansion and have serious treatment. Here they can't, and we all know that for an addict, if there's not a bed available at the moment they're ready to get treatment, then there's no point in offering the treatment. If they're not going to get the treatment at the moment they say they're ready, then we've lost them. And that's a major issue in Tennessee, and that's one of the reasons we're losing so many Tennesseans to this problem. I'm also the mother of a special needs child. I've been down your path, and my daughter's 20, and I am very, very concerned about the possibility of services being lost, and I don't see any addressing of what's going to happen there. It's all very vague, and I'm very concerned about those issues. When and where will we get the answers to these questions?
So, thank you for those comments. We appreciate that you think that there are opportunities for us to offer additional clarity. We will take that into consideration as we finalize the draft that we're submitting to CMS. Our next speaker is Mary Moore. Ms. Moore.
I'm another who initially thought I was signing in, so I will keep it short. I did want to echo just that there seems to be an asymmetry of information here, and I think that that is what is leading to a lot of the lack of trust. Also, just in personal experience, I know that when people go to take their kids to the doctor and they find out that their kids don't have insurance, they lose trust in the system. So there's already a trust problem, and then the lack of detail here is just emphasizing that. I also wanted to point out that in a very brief 25-page document, almost an entire page goes into some detail about how to prosecute members committing fraud, and then that they would be losing their eligibility and so on. I find it speaks a lot to the priorities behind this, addressing a non-issue while there's huge issues such as opioid use disorder issues that aren't mentioned in here. So those are my comments.
Thank you. Our next speaker, Michelle Johnson. Ms. Johnson, where are you?
Hi, I'm Michelle Johnson, and I am the Executive Director of the Tennessee Justice Center, and honored to be here with so many partners from TJC who all day, every day talk to regular Tennesseans from Memphis to Mountain City who need TennCare in order to thrive and need TennCare in order to have the final chapter of their life lived with dignity. Those 1.4 million people we are blessed to talk to and to dream with, and the constant barrage of political games, that these parents have to come here begging for their children's services, that they have to read in the newspaper what is the next game that someone is playing to cut these services it's really heartbreaking. We can do better as a state. There is no question that there is innovation and flexibility that needs to come to our state's healthcare system. The question just is, why do we need to do this untested, never before in the history of the nation? Why are we ending this partnership? All the flexibility, all the inefficiencies we can get today without putting at risk these children. Half the children in the state depend on this program. Half the children in the state, and we know what happens when they get health care. We know that children go on to earn more as adults. They're likely to go to college. They're less likely to die of preventable illnesses or have opioid addiction or alcohol addiction. We know that healthcare for children works. And we know that when seniors need long-term care, 65% of people in long-term care facilities, people with disabilities and seniors who have given their all to the state. They have given their all to the state. And they have to read that we're playing some sort of game, and they don't know whether or not they're going to be able to stay in their nursing home or whether they're going to be able to keep their care. This proposal is really, it's very, very disappointing, because the first part of it says it's not designed to cut care or to cut benefits. And then if you just turn the pages, you get to page 20, and guess what it says? We're going to ask for permission to cut benefits. We're going to cut benefits. And we just want to do it without even asking the federal government. Now, right now, the state could cut benefits. They just have to say to the federal government, this is how we're going to do it in a way that's safe and that saves money. Safe and saves money. If there's any benefit that they could cut right now that saves money and keeps patients safe, why aren't they doing it? So the first part is page 20. It is reducing services for people who need those services and will not get them without the comprehensive coverage that TennCare provides. The second thing is it destroys managed care protections, and these are HMOs, regulations developed by the federal government to say, how are we going to keep people safe? How are we going to make sure that doctors have a say and not HMOs? It destroys protections like, as Russ pointed out, actuarial soundness, timely payment, appeals processes, grievances, everything that you would hope for your own loved one you would have in place if your care was turned over to an HMO. The final part is very concerning, is this closed formulary. The closed formulary is a real problem, particularly for kids like on this Katie Beckett waiver. We just got all these kids who have rare genetic illnesses, and we're going to get them health coverage, but we're not going to provide them the medicine they need to thrive. There are lots of people who need drugs. We have a formulary now that has a way to get past the process and get people the medicine they need to thrive. And in fact, if you don't cover some medicine, it's going to be much more costly in hospital care and long-term care. So the final thing is just, the governor said he hopes to save $1 billion from this program. You can't understand this proposal in any other way in terms of what does it do for Tennessee? What does it do for Tennesseans who are sitting around their kitchen table at night wondering if they're going to have the health care that their family needs to thrive? This doesn't do it, except for that the governor says he's going to bring $1 billion to the state. And so the question I have is just, where is that money magically coming from? It's coming from the healthcare system that these kids and these seniors right now rely upon. We understand healthcare is the number one issue for voters, and we understand this is driven by a real desire to start to roll up our sleeves and address this. This is dangerous, and Tennesseans deserve better.
Mary Baggett, Ms. Baggett, other side of the room.
I'm not used to public speaking, but I'm having a problem, and I saw on the news that this meeting was going to happen, so I wanted to speak my piece if it helps. I'm 76 years old, and I've been on TennCare, but I haven't been on it now for about 7 weeks because my mail didn't bring the paperwork I was supposed to sign and fill out to prove that I still was eligible. So when I got a letter from Social Security telling me they were going to take $135 out of my check, and this next check on the 3rd is going to be the 3rd time they took it out, and I couldn't make it before, so I'm having even a harder time now. And if it weren't for my family, there's times that I wouldn't have anything to eat because my sister took me to the grocery store and bought me $50 worth of groceries, and that is so humiliating. I can't even take care of myself. I've tried so hard to hold on to my home because I wanted to leave my children something. I didn't want to go out of this world without leaving them something. And I've struggled to hold on to my home. And it's been hard. I used to have a full life. I went places. I went out with friends and ate and all that kind of thing. But I can't even do that now. I've got 2 friends that want to take me out all the time, but I don't let them because I can't pay for it. I've got a splitting headache. Anyway, they still haven't accepted me back. They keep putting me off, telling me, you know, well, maybe you need to send this in. Well, I've done everything they've asked me to do. And I call and check, you know, about once a week because I don't want to nag them too much. But they just say, well, they haven't made a decision yet. And I can't keep going like this. I've borrowed money to keep going, and then I have to pay the interest on that borrowed money. And I just keep getting further in the hole. And I can't keep that up. I mean, $135 probably don't sound like a lot to a lot of people, but it means a lot to me. And I guess that's all I got to say. Thank y'all.
We have one more name who signed up to speak this afternoon. Unfortunately, and I apologize for this, but I'm not able to read it. If you think you signed up and I haven't called your name yet, would you raise your hand? Okay. By my clock, we have about 5 minutes left. Is there anyone who didn't sign up to speak who would like to offer a comment at this time? Jordan, this person back here. And we have about 5 minutes left if you could sort of.
My name is Beth Urbanzik, and I'm a behavior analyst in the state of Tennessee. And many of the behavior analysts across the state provide services through TennCare to children. And when we went through this proposal, there is no detail. So we don't know how that will impact our services, how it's going to impact children. And I think I'm just kind of echoing some of the other statements that I've heard from other people. There's just so little detail in this proposal that it's hard to give you written comments on what we think. I've gone through the Sycamore Institute report. I've gone through the Tennessee Disability report. I've read through what the daily paper in Memphis has written and what the Tennessean has written. And all these people are saying that there's a lot of flaws with what's going on with this block grant. And I support that. We need more detail to know, because this has real life implications for children. And if we can't help take care of our children, here the pediatricians, their life trajectory is very poor. So thank you for taking the time to hear us.
Thank you. I want to thank everyone for being here this afternoon, for your interest in the TennCare program, for your interest in Amendment 42. We appreciate and value all the input that's been offered. I do encourage everyone, we've taken down all of the comments that have been offered today, but I do encourage everyone to send in your written comments between now and the deadline. Particularly if there are areas where you think that the proposal should go into more detail, that's helpful for us to know if there are specifics you would like to see. We do have 2 other public hearings currently on the calendar. One will take place tomorrow in Knoxville, one on Thursday in Jackson. We are also working in the process of scheduling 2 additional hearings, one in Chattanooga and one in Memphis. So look for additional information about those. With that, again, thank you for your participation and your attendance. I'm going to call us to a close. We're adjourned. Thank you.